Dr. Jennifer Harris has over 20 years of oncology-focused experience, including involvement with 20 investigational new drug programs and 2 new drug application submissions. Her experience encompasses drug development planning, budgeting, and management of oncology trials, with particular expertise in first-time in-human through proof-of-concept trials. Dr. Harris has clinical experience at large academic research hospitals and the National Institutes of Health and National Cancer Institute intramural research program, and is currently associated with Bavarian Nordic, an international biotechnology company pursuing the development of active immunotherapy targeting major cancers, one of which is prostate cancer. A lead product candidate is ProstVac, a therapeutic vaccine candidate and immunotherapy product candidate for advanced prostate cancer that is subject of an ongoing pivotal phase 3 clinical trial. The vaccine has the potential to significantly extend the lives of men with advanced prostate cancer, where limited treatment options are available, without affecting their quality of life. The life expectancy for metastatic prostate cancer patients reaching the stage of hormone resistance is only 18 to 24 months. So it goes without saying that improved therapies for metastatic prostate cancer patients are urgently needed.
I'm sorry, everybody. I know it's been a long. I'm sorry. You done?
No.
Okay. So I'm here today to talk about our ProstVac trial. But before that, I just want to thank Mr. Farrington and Mr. Bass and all the members of PHEN. You all are doing a fabulous job. I myself, I've spent 20 years advancing cancer therapies, but I have learned a ton at this meeting. In addition to devoting my personal life, to creating new therapies for cancer patients, the last 3 or 4 years, specifically in prostate cancer, I personally have been profoundly affected by cancer in my life. I lost my mother, sadly, to a colorectal cancer when she was only 52. My brother died of stomach cancer when he was only 35. And just 2 months ago, my own father was diagnosed with metastatic prostate cancer. Sadly for him, he had been receiving screening. He'd been getting his PSA. Unbeknownst to me, he was actually, he read a book somewhere that said most men die with prostate cancer, not from it, and ignored his rising PSA. He had a PSA of 75 when I learned about this. And I got him to the urologist, and sadly we found out that he has very, very advanced metastatic bone disease. And the next probably year or 2 of his life aren't going to be pleasant. So I just want to say to PHEN, keep educating, keep going out there, not just screening, but getting the proper follow-up. And as you do that, you have my commitment to continue working on new therapies. And one of those therapies is what I'm going to talk about today. And I'm really excited to explain to you about what we're doing at Bavarian Nordic. And this is going to be an odd presentation. So I am not going to go through prostate cancer overview. We all know it's a terrible disease. You all know this better than I. We also know that it disproportionately affects African American men. Dr. Jarrett yesterday and Dr. Benjamin went through this extensively. We also talked in Dr. Horton's presentation about the need for clinical trials and some of the reasons why patients may not be participating in those clinical trials. I only want to expand on one point, that being the last bullet down here. Does drug effectiveness vary across races? Using blood pressure as an example, we know that ACE inhibitors don't work in African Americans to control blood pressure. Why do we know this? Because we had adequate numbers of patients in the clinical trials that showed us this. So we need to make sure that we're doing the same thing for cancer treatments. Dr. Jarrett yesterday talked about screening recommendations, for no screening in some patients. And that was based on data that did not include the African American population. So we absolutely want to make sure that we get patients in clinical trials. So as these new therapies emerge, we know whether or not they're appropriate in all populations. So right now I'm going to move into quickly the immunotherapy. Can I get just a show of hands of who in this room is familiar with the term immunotherapy? Okay, so most of you are. So immunotherapy is basically using the patient's own immune system to seek out and attack cancer. This is a really exciting new area of development. There's one approved immunotherapy on the market, and it's in prostate cancer. You heard from Dr. Bob Tyler yesterday about Dendrion's Provenge. Bavarian Nordic is doing something similar, except we're not requiring extraction of blood or anything from the patient to activate the immune system. So what's really interesting about immunotherapy as opposed to chemotherapy, which I've spent most of my career developing, and even targeted therapies, is the side effect profile is really non-existent. All we're doing is taking that immune system that we know is very, very efficient in most patients at seeking out cancer cells and eradicating them. Patients who actually develop tumors, something went wrong in the immune system. So what we're doing is trying to help that immune system get reactivated and go out and do its job. So this is just a graph of the natural history of prostate cancer. Here on the x-axis, that's years, and up on the y-axis, it's tumor volume. As patients first get diagnosed, they have generally low tumor volume, if unlike my father, but most men are, if they have their prostate screenings, it's going to be a low burden of disease, and they're often treated locally with a prostatectomy or brachytherapy. Eventually, though, in some patients, their PSA will start to rise, meaning that the cancer is growing somewhere in the body. We might not be able to detect it yet by scans, but we know that it's growing. So at that point, most doctors will advocate using some sort of androgen deprivation therapy, stop the testosterone that's feeding the growth of the tumor. At that point, they'll continue on probably for a year or two, doing well, and then the PSA starts to rise again, meaning that the cancer cells outsmarted the ability to shut down this testosterone. They figured out how to grow even without testosterone. So that's when patients really start to progress, and historically your options were chemotherapy. As you can see, there's a red arrow for immunotherapy. This is where we're developing our therapy, is as patients are starting to become resistant to the androgen deprivation therapy, this is when we're looking to institute immunotherapy. Can we actually use the immune system at this point to stop any further progression? So why is prostate cancer a good target for using the immune system? Prostate cancer is generally a slow-growing tumor. When we use immunotherapy, it's not like going in like what I call the carpet bomb of chemotherapy, where it goes in there and just sort of blasts every dividing cell in the body. Immunotherapy actually takes a little while to ramp up. So if you have a slower-growing tumor like prostate cancer, it gives the immune system time to generate an immune response. In addition, if you give immunotherapy where the red arrow was on the previous slide, these men have not been exposed to a lot of chemotherapy and things that might actually sort of dampen their immune response, or kind of, we know that chemotherapy kills the immune system. So if we give immunotherapy before chemotherapy, it has a better chance of working. And in addition, prostate cancer is a really excellent target because we know that there is a specific antigen, PSA, which we're all familiar with, to target. And indeed, our immunotherapy approach targets prostate-specific antigen. So we actually have completed a phase 2 trial. Yesterday, you heard Dr. Horton talk about the different phases of research. Phase 2 are sometimes called proof of concept studies, generally in less numbers of patients. And we used our vaccine in a phase 2 trial, and the vaccine consists of a tumor antigen gene, which is PSA, along with 3 co-stimulatory molecules. We know that the immune system often works better if you send in other signals to help it along. So what the founders of this, and a lot of the work was done by Dr. James Gulley at the NCI, what he did is came up with a brilliant idea to use a viral vector, vaccinia, which has been used for 100 years to basically vaccinate patients against smallpox. And what he did is just brilliant, is he loaded in to that smallpox vaccine, the vaccinia, he put in prostate-specific antigen, so that when you inject patients with this, we know that their system is going to react to the vaccinia, and then the prostate-specific antigen is in that vaccine as well. So as the immune system starts to generate a response against the vaccine, it also generates a response against the prostate cancer. So it's almost like tricking the immune system into attacking the cancer. And this is what I mean by helping along our immune system. So, as I just mentioned, the ProstVac vaccine is comprised of 2 viral vectors, the vaccinia, which is the first dose, and then foulpox we use for the next 6 doses. It's delivered through 7 subcutaneous injections, so there's nothing extracted from the patient. They simply have to get these little shots under their arm. It's delivered over 5 months, and then what happens is we follow patients for some different endpoints. In the interest of time, I think I just described this. Our phase 2 was actually the active component. Several people have mentioned that to get new drugs approved, we have to look at both active and placebo. It's called a randomized trial. So our phase 2 trial looked at some patients who received active component and some patients who actually received empty vector or just placebo. And then we looked to see if there was a difference in some endpoints. The endpoints that we looked at were progression-free survival after 6 months. We also looked at PSA. Interestingly, we didn't see any response on either of these 2 endpoints. And this is not inconsistent with some other immunotherapy approaches out there. What we did look to see a big difference in, though, is overall survival, which is really the holy grail. This is what we're really interested in doing, is extending the lives of our patients. So what happened was, again, you've seen Kaplan-Meier curves over the past couple of days. The red line are patients who actually were randomized to receive the active vaccine. The blue line are patients who were randomized to receive placebo. And what you see in our phase 2 trial was a difference of survival of 8.5 months. This is pretty exciting data. We were excited enough about it that we're now running a larger phase 3 confirmatory trial, which will allow the FDA to review the data and get this drug on the market, this vaccine on the market. I also want to talk just quickly about the common adverse events. Those of you who have had loved ones or you yourself may have received chemo or some other targeted agents know that there's some pretty significant side effects. Immunotherapy does not have the same side effect profile that we're used to seeing with cancer treatments. Most of the adverse events were related to injection site reactions. As we inject the vaccine under the skin, it causes irritation. But that's actually a good sign. That means that the immune system actually recognized this is a foreign particle and it's generating a response. We also saw some fatigue, a little bit of constipation, diarrhea, but nothing like the major neutropenic events that you see with chemotherapy or the vomiting and nausea. So overall, immunotherapy is a very attractive approach. So now I just want to close by talking about our phase 3 trial. All of you have this in your brochure. This talks about our phase 3 trial. We're looking to enroll 1,200 patients at 250 sites. Right now we're at 13 countries and counting. The study duration is 5 months, and then there's a long-term follow-up period where we're going to look at survival. This is also a randomized trial. There's a placebo arm versus an active arm. The lead PI, as I mentioned earlier, is Dr. James Gully at the National Cancer Institute, and the co-PI is Dr. Phil Kantoff up at the Dana-Farber. So here is a map of where some of our sites are. As you can see, we're widely distributed across the U.S., so I really encourage all of you, if you know somebody that may have minimally symptomatic prostate cancer, they've failed their hormonal therapy, and you think they might want to explore an option with immunotherapy, that there's certainly going to be a site, within close proximity to where they live. I also want to mention that Ernest Kitt in the back of the room, if you'll raise your hand, Ernest, is my colleague, and he can provide more of these brochures if you need them, as well as contact information if anybody wants to know about the trial. Just real quickly, patients, again, anyone who's minimally symptomatic or asymptomatic with their bone mets. They don't have any other visceral metastases, meaning they don't have anything in their brain or their lungs. And patients, again, we don't want patients who have a lot of pain because that means they're probably more advanced and probably their immune system may not give itself time to activate before they progress. And these are pre-chemotherapy patients as well. And they have to have a life expectancy of about 1 year or more. So survival is our primary endpoint. We're also looking at things like the proportion of patients at 6 months who are event-free, meaning they haven't had bone fractures or anything like that. And then, of course, we're going to look at an expanded population of safety patients. This is the design really quickly. It's a 3-arm study, 400 patients in each arm. One will get the active, 2 of the arms will receive active, 1 will receive placebo, and then there's an adjuvant called GM-CSF that we're giving along in 1 arm to see if it actually can help stimulate the immune response even more. Again, 7 vaccines. The first 3 are 2 weeks apart, and then 4 weeks. The total treatment is 5 months. Just want to close talking about participation of African Americans. This is a priority for us, as it is for everyone in this room. Again, we cannot make good recommendations on whether a specific therapy is helpful for a specific subset of the population unless we have adequate representation of that population in the trial. So it's a real priority for us to get, at least 10%. We would obviously take many more African Americans that want to be in the trial so that we can know this is a disease that we know is more aggressive in African Americans, that's disproportionately representative in African Americans. We really would need your help in getting the word out and getting adequate numbers of patients on this trial to know whether or not this is going to be a good therapy for African American men. So thank you.